everyone, welcome back to another exciting episode of MedSynapse podcast series. I'm your host, Hetvi Shah, and today we're delving into the fascinating world of interventional radiology, a groundbreaking specialty that blends diagnostic imaging with minimally invasive techniques to revolutionize patient care. Joining me today is the highly accomplished Dr. Vikas, a distinguished radiologist with an MBBS, DNB, FRCR, and a fellowship in vascular and interventional radiology. Dr. Vikas is an expert in cutting edge image techniques and minimally invasive procedures with a profound interest in vascular interventions, oncological interventions, and image guided therapies. So, thank you, Doctor, for taking your time as to join today.
Yeah, thank you, Hetvi. Thanks for inviting me.
Yeah. So, doctor, let's start with the basics. So, could you explain what interventional radiology is and how it differs from traditional radiology or other surgical fields?
Okay. Intervention radiology is a branch where we use image guidance like ultrasound, X-rays, or CT scans, and sometimes MRI to treat or diagnose the patient. These are the minimally invasive procedures which will help us diagnose or treat the patient. So this combines both the diagnostic radiology to a clinical aspect, which brings all the utility of the diagnostic radiology to a level where it can be applied at clinical level and help patients alleviate of their symptoms or help them diagnose the condition they have. Coming to difference between the intervention radiology and traditional radiology, the main purpose of diagnostic radiology is diagnosing a disease. Like somebody has a cough or something, they'll come to us with an X-ray or CT scan. The diagnostic radiology tells them what is there or what would be the differential, whether it's an infection, cancer, or something. But the intervention radiology goes one step ahead, where we use ultrasound or CT. If there is a mass lesion or something, lymph node is enlarged, we go ahead and do the biopsy and give a definitive diagnosis to the clinician for better treatment and for a better diagnosis and further management of the patient. So next, how when we go to difference between the intervention radiology and other surgical fields, intervention radiology is a what do we call, like it's a very fairly simple as compared to other surgeries in terms of anesthesia or in terms of skin incisions. Like for most of the surgeries, we will have to take general anesthesia when we operate, or we have to give some blocks or lumbar puncture to give spinal blocks. And while as in intervention radiology, it will be most of the procedures will be get done under local anesthesia, or we might have to extend to intravenous sedation. That's not general anesthesia. That's a form of sedation. Depending on the procedure, the plane of sedation differs in intervention radiology. And also with related to incisions, I'm not taking into account all of the surgical procedures, but most of them will involve incisions for at least 3 to 5 centimeters, and abdominal surgeries might involve large incisions in the abdomen or pelvis. So while this taking one example here for the uterine fibroids, where intervention radiology offers uterine artery embolization, while the conventional traditional treatment is hysterectomy or other procedures like myomectomy can be done. So in uterine artery embolization, we just give a nick in the groin just to pass a small needle and catheter so that we can treat for the fibroids. The same technique is also applied for postpartum hemorrhage, where the females might have bled due to their pregnancy or post-pregnancy. And coming to the recovery time, as soon as 6 hours is over for the femoral artery punctures, if we have taken access, the patient will be ambulant in 6 hours. If it's a radial artery, then it's probably 1 or 2 hours just for the observations. And that's the recovery time. Like the patient will be ambulant in within a day in most of the procedures with relation to intervention radiology, until and unless patient is sedated for general anesthesia, where sometimes it is used for only treating the aneurysms, intracranial aneurysms. And then the manipulation of the tissue, like we don't go touch the organ there. While as a surgeon, they go in, they see the organ through their eyes and they manipulate the organs and do it. So that's the surgeon's expertise, and our expertise is here, where we do not touch or open the patient, but we treat through catheters and needles. And coming to the conditions, I wouldn't talk about conditions because it's a case to case basis approach. Some patient might be fit. I brought up the example of fibroids. Few patients might not be fit for urinary embolization. Such patients will be referred back to the gynecologist for conventional treatments. While as very good patients, I mean, fit patients for the intervention procedures, we will take them for urinary embolization and they'll be good to go back in home the same day sometimes or in a day or two. So, in summary, the intervention radiology is a branch which is an evolving and innovative branch which bridges the gap between the imaging and the clinical aspects of the patient to diagnose and treat.
So I actually really like the way you mentioned that it actually bridges the gap between the specialties. So it actually serves as bridging the gap rightly. So now speaking of bridging gaps only, doctor. So could you tell me that how does IR serve as a bridge between radiology and interventional practices? And could you also share some examples of collaboration between interventional radiology and other clinical branches?
You can let me start how intervention radiologist is made. Whoever has undergone 3 years of residency in radiology will be taking up a fellowship or DM. Now we have many more DM seats in our country. So then they will be trained to do certain set of procedures. These are the minimally invasive procedures. Almost 99.9% or all of them are minimally invasive procedures in intervention radiology. So whoever has learned radiology for the 3 years as their postgraduate course will be trained specially to do these procedures. So they are utilizing their 3 years knowledge of the equipments like ultrasound, CT, or fluoroscopy to perform procedures on patients. So they are bringing the diagnostic radiology tools to help patients here. So that is how IR is bridging between the diagnostic radiology to the bedside or the clinical branches. And you asked about the collaboration with the other clinical branches. So I'll pick up an example and then I'll go ahead. We know about breast carcinoma. So once a breast carcinoma patient has come to a general physician or an oncologist. So once the patient is there, they want to know, is this really breast carcinoma or not? So to confirm the diagnosis, we need to perform a biopsy, means taking a small sample of tissue to look it under microscope and also to confirm what kind of cancer it is. And there is much more complicated immunohistochemistry, what we call IHC, to further treat or plan a treatment plan for the patient, so that the surgical oncologist or the medical oncologist will pitch in, or the radiation oncologist also to pitch in and decide what is the correct treatment plan. All these are based on histopathology reports and IHC reports. So that needs a tissue sample that is done by IR. And then once the cancer is diagnosed, if it's a cancer, so what we do then is we will have to give a neoadjuvant chemotherapy in most of the cases. In such cases, we will have to put a localization marker. Then, after neoadjuvant chemotherapy, imagine the tumor has vanished. The surgeon will not be able to feel the cancer there, the whatever we call lump. So we will have to help the surgeon to identify the lesion where exactly it is for him to excise the lesion. So once it is done, then if there is any post-operative collection in the operation bed, we will have to go and put a needle to aspirate that collection. I am telling all this because the role of intervention is there everywhere in the clinician's part. It involves almost all the branches, and we can do. This is one such example. And going ahead in this breast cancer, if the patient is coming for surveillance, imagine the patient is declared cancer free and the patient will be under surveillance under oncologist. Then if they have some new lesion in the bone or lungs or somewhere else, we might have to put in a needle and take sample again to see whether it is the same lesion or it is a new lesion, so that it further helps clinician decide whether they have how should they manage, whether this is the cancer from the previous one or is it something new. So that's how IR helps. And another example, non-cancerous example, in nephrology, where the patient will need a dialysis. In case of acute emergency or planned emergency, they will have to need a vascular access to dialysis. So IR helps in getting a catheters. We have classified it into tunneled and non-tunneled, temporary and for long-term catheters. So we will help them in getting a maxilla to do dialysis. And in patients who has already have AV fistula, arteriovenous fistula for the dialysis, which is created by vascular surgeons. So in that such cases, when in the long term, if the fistula is not responding correctly or unable to dialyze correctly with the AV fistula, we go in and do fistulogram and see where is the problem, whether the artery which is feeding the fistula is the problem or the draining vein is the problem. And then we can treat accordingly with fistuloplasty, or we can embolize the extra draining veins. And also in nephrology, the other application is the renal biopsy, where we can help the clinician nephrologist diagnose what exactly the condition is. And in dialysis patients, routinely they would get their fluid built up in their lungs or in their tummy. So we will have to put in a needle under ultrasound guidance and drain them. These are the two examples where I have told you how IR collaborates with other clinical branches. So there is a role of IR in every step where the patient will be diagnosed or treated.
Yes, I think that is such an incredible answer, and I think multidisciplinary approach is actually something that really works in such cases that you've mentioned and highlighted as well. The next question would be: what are some ways in which IR contributes to patient care that are unique or complementary to other specialties?
Where patient IR contributes to patient care is again the same. Here, one thing I would like to put a limelight is where we can take our ultrasound machines to the bedside and perform a certain set of procedures. For example, if, as I said, in nephrology patients, I might build up fluid in the chest or in the tummy, where we can put a needle under ultrasound guidance. And the same goes with any surgical bag. If there is a pus collection somewhere in the body and the patient is admitted in ICU, we can go into ICU, take our machine to the ICU, and then we can drain. And coming to the procedures and how do we prepare the patients for the procedures is quite fairly simple as compared to any other actual surgery. So here we will give one overnight fasting and very few simple blood tests like hemoglobin and their coagulation parameter, which is very important for us. And then as we use contrast for vascular procedures, the serum creatinine is very important. These are the very few basic investigations and might add up on another 2-3 blood investigations if necessary, or based on the procedure what we are doing. And also says that we will have a pre-procedural investigations done. I spoke about uterine artery embolization in such cases to evaluate the patient and to see if the patient is deemed fit for uterine artery embolization. We will get an MRI prior to the procedure so that we know this patient is a fit candidate for the procedure. So these are the few things that IR gives to the patient, and the preparation of patient to the procedure is fairly simple.
Yeah, thank you for sharing that, and I think that was really interesting to know. So now, could you walk us through the spectrum of minimally invasive procedure that IR covers?
This is the spectrum is very huge because it caters to a lot of departments and almost all of the departments you can name, whichever is a clinical branch. I'll go through few headings like a few of the important topics which I can cover. For example, if a patient had accident and he has come for an emergency room, imagine, and he is bleeding from some artery. So that's from where even the IR role starts. Once the CT scan or something is done to diagnose that, usually a CT scan, we can go and embolize the bleeding artery and stop him having a blood loss. That's where one role is. Or else if the patient has some blood collection in the chest or tummy, and if it's indicated, then we can put in a tube to drain the blood there. Okay, since I'm talking about vessels, I'll go to peripheral arterial disease and venous disease. So in peripheral arterial disease, what happens is in chronic smokers or in certain diseases like Vikas disease, there will be narrowing of the blood vessels. When it's for such blood vessels, we have to put in a balloon and open it up, or we will have to put a stent and keep the patent so that the patient doesn't lose his limb. If the patients are in early stages, we will be able to do this procedure and we can be able to save or salvage the limb for the patient. Usually this is seen in the legs, like the lower limbs. Coming to the veins, varicose veins and varicosities are very common conditions which will lead to chronic venous disease in the legs, which you might have seen as a black, thick skin in the foot or the lower legs. So, for them, we can offer radiofrequency ablation of the veins or sclerotherapy of varicosities. So, all these procedures are dependent on case to case basis, and we will evaluate the patient with an venous Doppler and then take a call what is good for the patient and then take. And then if we talk about some infection, the most prevalent thing in India is tuberculosis. Usually they come in with chest infection or the enlarged nodes in their neck area. So in such cases, a small needle into the node, taking out the pus or taking a sample from the node will definitely help us in making a definitive diagnosis so that clinician can treat with much more confidence with an evidence. And if I go to inflammatory part of the diseases, then for example, many might of you heard about the pancreatitis. So in pancreatitis, it starts with imaging. Then patient might be admitted in ICU. Then he might have a correction in his chest or abdomen again. Then we have to put in a needle and drain. And also sometimes what happens is when pancreatitis is there, pancreatitis might full of pus or just fluid correction. So that needs to be drained to stabilize the patients in few life-threatening conditions. Or in common, people might have heard about gallstones or cholecystitis, what we call as cholecystitis. That's inflammation of the gallbladder. In such cases, if the patient is not deemed fit for surgery due to his age or his general condition, probably he's in sepsis or whatever. So in such cases, percutaneous cholecystostomy will help a patient come out of sepsis in such cases and help him transiently until he's fit for surgery. Then the surgeon can take over the case and treat him. And then, as said, in tumor, starting from the diagnosis, biopsy, then knowing the diagnosis, then certain set of cancers like HCC have very varied options for treatment from intervention radiology, starting from ablation to vascular procedures like TACE and TARE. TACE is transarterial chemoembolization, TARE is transarterial radioembolization. So IR itself can offer varied procedures and treatment options. And coming to the innovative procedures recently, we have genicular artery embolization or genicular nerve ablation for osteoarthritis of the knee, where the target of the procedure is to reduce the pain. We have seen a lot of cases, old age patients who has knee pain and are deemed unfit for the surgery because of their comorbids. They might be heart patients or they might be obese and unfit for the surgery. So in such patients, to help them do day-to-day activities, to walk around their house, to eat food or to go to washroom, to reduce the pain, genicular artery embolization and genicular nerve ablation is a new procedure which is kicking up here. And the other procedure is transarterial microembolization, where we have we can go and treat many chronic pain conditions. For example, plantar fasciitis is one, or the frozen shoulder is one of those conditions where patient might have tried a lot of other procedures or injections, intra-articular injections, and they have taken steroids and not responded. But this transarterial microembolization is showing promise in pain relief.
Yes, I think that is such an incredible answer and an in-depth explanation that you've given me, and also it is really exciting to hear about the advancements as well. So now, my last question would be: where do you see the field of IR heading in the next decade, and what new applications or technologies do you anticipate becoming standard practice?
IR would be in the next decade. I would say IR will be with any other clinical branch associating very closely. That's where both IR and non-IR clinical branches will be able to deliver and give an optimal good result to the patient care and help them alleviate of their symptoms. You might call cancer. You might declare somebody as a cancer free with the help of both clinical branches. And new applications is that in India at this point, not many of the medical colleges and tier 2 cities have intervention radiology practice. So in probably in the next decade, I would expect IR to rush in there to all of the medical colleges and in tier 2 cities also, where the role of IR will be helping many patients and a lot of patients in patient care. That's where IR will be associated with other clinical branches in the next 10 years and very closely.
Yes, I think the future of IR really sounds promising, and I think it is so inspiring to know that this innovation in the innovation in this field actually will continue to redefine modern medicine as well.
Yeah, this is like using a new technology to help old diseases, I might say that.
Exactly.
So you are using a fairly simple techniques, but advanced techniques to treat very common problems. And the one more advancement in this is treating the thyroid nodules, which was conventionally treated by thyroidectomy. Now we can do radiofrequency ablation of the thyroid for benign diseases of the thyroid. This is another
Exactly.
innovation that's there, and people are getting to know. The problem is that people are not aware of the procedures about the IR.
Mhm.
So once they know it, they'll definitely ask as an at least as an option, whoever the clinician whenever they offer the treatment option. So offering IR procedures in treatment options is very important, and making people understand what intervention radiology is and what intervention radiology can do is very important.
Exactly, and I think it is such so exciting also to hear, and I think with the right kind of awareness, the people would be more knowledgeable, and they would gain more knowledge regarding such new advancements as well. So
Yes,
now,
definitely.
Doctor, as we wrap up today's session, I would like to thank you for joining us today. And it's been an absolute pleasure to have you today. And your insights into the innovations and actually application of interventional radiology are both enlightening and inspiring. And thank you for giving that in depth knowledge about interventional radiology from the basics till the advances. Thank you so much.
Thank you very much. Thank you.
And to our listeners, thank you for tuning into this episode. And if you found this discussion helpful, don't forget to share it ahead. So, and remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So, until next time, stay aware and spread the right kind of knowledge. Thank you.